My name is Jessica Ching. I'm an assistant professor and the surgical director of the craniofacial team at the University of Florida. Been in practice for 5 years.
My name is Dr. Travis Weeks, and I'm an orthodontist and dental facial orthopedist. And I've been practicing, almost 10 years or more than 10 years. Right around 10 years.
My name is John Obie. I'm a board-certified plastic surgeon here in Jacksonville, Florida. I started my private practice in January of 1981.
Was in dental school. I knew that I wanted to be an orthodontist, so my senior year you had to do a kind of a semi-thesis paper, and I actually wrote one and researched cleft palate. And I wanted to understand the entire process because it's very complicated.
In residency, you're still under supervision. So there was, my attending physician was with me and participated in the care as well. And so it wasn't an anxious thing, it was an exciting thing.
The first encounter I ever had with a patient, with a person that had a cleft, was as I was growing up. And what I remember is they looked different and they sounded different. And so they were easily identified and to some degree isolated, which was truly unfortunate. Through no fault of their own, they were isolated and segregated to some degree. I guess that kind of raised a question in my mind in terms of, what can be done.
At least 100 per year of those cases. Yeah, I would say about at least 100 a year. I do at least 2 a week. So that's what I'm estimating it on.
I think the biggest thing is seeing patients when at the beginning where they really want it to be affected and you're ready to, what you can do, but you also know that it's going to take 2 years just to get to a point where the patient's going to recognize how much better it looks. Orthodontics is not instantaneous. So I think that could be sometimes tough when patients come in.
Stressful experiences that I've had have been related to interacting with the families and trying to ease their stress about what the child is going through. And so those moments are really emotionally draining for the family, and they require a lot of empathy and patience on my part to make sure that I communicate effectively. So I think those are probably the most stressful experiences, to make sure that I do a good job communicating and walking with the family through whatever anxiety or frustration they may have.
With palate surgery, our goal is to restoration of normal speech. In terms of stressful, and there is a procedure where we actually attach the soft palate to the back of the throat. That's called a pharyngeal flap. And that procedure typically is going to be done and the patient kept overnight, and they'll go home the next day. The most difficult encounter, if you will, I had was when we did that procedure on a 5-year-old who for 5 days refused to let anybody near his mouth. He would not eat, he would not drink. I mean, it was torment to the parents. Mm. And the bottom line there is, in medicine and surgery, we have to always remember it can be a very humbling experience. Even when you think you have the experience and you've seen it all, tomorrow is going to be another day.
It has drastically changed how we practice because we do a lot more telemedicine now, and via Zoom or our electronic medical record, we can do it that way. But with those things, it's important to have eye contact, to have good internet connection becomes really important, so that they can gather everything that I'm saying and I can gather everything they're saying, so that the conversation is smooth and they don't feel frustrated by the mechanics of the telemedicine.
And the lip. The lip is not as much of an issue. It's more, you could have a cleft lip and typically if you don't have a cleft in the alveolus or the part where the teeth is, the lip is not that much of an issue. You could have a partial cleft and that does typically nothing for me. when the palate or when the alveolus, which is the supporting tissues of the teeth, the bone there, when that is affected, then sometimes there's one or two teeth that may not even form correctly. There's definitely not bone there. And for teeth to be able to move properly, they have to have bone. So you're working in a different environment.
Very closely tied together, actually. So a lot of the functional aspects are very closely tied to the impact that they have on a patient's self-esteem and their confidence. So I would say it's both would be the true answer. But in the conversations that I have with the family and the patient, we discuss both.
Oh, absolutely function. There's the insurance industry, which is notorious for thinking that all plastic surgeons do is vanity related. That's an editorial. The insurance industry has accepted certain, if you will, definitions. Reconstructive surgery is that which is done in an effort to restore areas that were damaged either, by birth, by trauma, by surgery, back to the generally regarded normal appearance. Cosmetic surgery is when you undertake a procedure for improvement. You're already normal, but you want to be better. There is no question that what we do is functional. Yes, there may be an aesthetic. Well, hopefully there's going to be an aesthetic benefit for the visual components, the lips, the nose, that sort of thing. But the primary procedure is functional, is to restore these children the ability to speak properly, to eat and swallow properly.
I think I do both. I think you always want to work on somebody that, or I'd want to be worked on by somebody that I consider a friend and I trust. I think that's, if you can establish that relationship, I think that's extremely important. I want my friends to be straightforward with me, and let me know exactly what, I was going to face. I don't do it as, some people come in here and it's not ideal. Things are not ideal, but you're able to say, look, this isn't ideal. And I know it, and I think you probably know it. And so let's find a way to fix it.
So the shortened way that we refer to that is called VPI, because vilopharyngeal incompetence is really long. So for VPI, the way that relates to cleft palate is when you repair the palate in infancy, it may look closed on the surface, but it doesn't mean that the muscles that need to do the work for the palate actually function properly. So even if you repair them perfectly with surgery, there's no guarantee of the function long term. So we monitor their speech very closely to make sure that they function properly.
In our team, we have pediatrician, we have speech pathology, we have audiology, ear, nose, and throat, pediatric dentist, orthodontist, oral and maxillofacial surgery, social worker. We have access to geneticists. We have a neurosurgeon. We have plastic surgeons, and we have certainly our nurse coordinator and a psychologist. Imagine having a child that needed the services of each of these, and I didn't count, but there's probably between 15 and 20. Mm-hmm. If your child is being treated by all of the above, you have to make that many visits. And then we're counting on how long is it going to take those 15 or 20 people to intercommunicate and come up with a treatment plan. There is no question that is the absolute best way to manage this condition. Mm-hmm. It's the most time efficient and productive all the way around for the parents, for the child, and for the staff. It really is the only way that this condition should be handled.
Sometimes it's the way that they sit. They sit taller and they're smiling more than they have before, or they'll wear their hair differently. So sometimes some people do things unconsciously. So they may, grow facial hair or wear their hair to cover part of something that they are embarrassed of. And so the next appointment, they'll come and their hair will be short and their whole face visible. And so, and they're smiling. And so, they've got to feel good.
I think you see it go up and down. And I think that comes with awareness, self-awareness. When they're very young, they don't see themselves very different than any other kids. And then as they become older, that's when another kid might point something out. What's that? What's this? And so that's when some kids can become very self-aware, and unfortunately they can become, it bothers them.
The least favorite part is probably health insurance. Having to deal with health insurance and fight with them to get these procedures covered. It's very frustrating. If I say a child needs a surgery and the insurance company says no, they don't, then I have to argue with the insurance companies. I think my favorite part is getting to know them over the course of their whole childhood up until adulthood. It's one of the rare types of practices where I know the patient from birth until adulthood. So they're always my patient. So I like that I get to know them. I know their families and they trust me.
I see so many practices where they get these, canned images or they get models. And the thing is, there are so many beautiful, just absolutely beautiful young ladies and really handsome guys around these areas. And they're just wonderful people. Why would you not showcase what we have in and around our community? And had another patient that was cleft lip, and he had some mental deficiencies, and he came back, and he's working at Publix, and he's got a great smile. He's got he's doing everything that he can do in his life, and it's a wonderful thing. And to feel like you had an indirect hand at being a part of that, I think it's a special thing.